It is a true pleasure to be here with esteemed colleagues who I admire and look up to, and I look forward to joining this year of awareness and action. Many of you know the data, but let's just go through it because the numbers are important to remember as we communicate our message. 260,000 women per year have an AMI, 30,000 of whom are under the age of 55. AMI mortality is higher in women than in men, both at 1 year and at 5 years, and more women are likely to go on to develop heart failure and stroke. Younger women have worse health outcomes, as you've heard Dr. Vogel refer to. This is the age-sex interaction, which is important that we dig deep on. And there's persistent disparities, especially in the United States, where Black women suffer higher rates of AMI, present at an earlier age, have more cardiovascular risk factors at presentation, and have worse health outcomes. Another aspect of this is that women have unique endotypes of MI, the MINOCA, myocardial infarction, and no obstructive coronary artery disease. We know about it, but we're not doing enough to diagnose it and then to identify treatments to specifically improve outcomes in women. So the big data will tell you that MIs are decreasing, and this is phenomenal. We're pleased about this. These are data that show that over the last, they're already a decade old, there's incredible declines for men and for women. But if we take a look at the data from other studies, and Dr. Vogel pointed to a few others, in young women, actually, the rates are going up. And if we look at what's happening at the point of care, women are at greater risk, yet, as noted by Dr. Gibson, they're getting less evidence-based medical therapies at the point of care. So on the graph on the left, you see that the therapies that are more likely to be given to men than women, and you could just look down the board and they are all more prevalent in men. This is a study by Emily Buchholz and Harlan Krumholtz looking at years of potential life lost post-MI. And here they stratified the data from the cardiovascular project and showed the data by race and by sex. And here you can see that Black women lost the greatest percentage of life years, followed by white women, and then Black men. And the differences were most pronounced in younger patients. Again, that age-sex interaction. And I'll put age-sex-race interaction in there too. So we know that women are older at first presentation of MI than older than men are. They have more cardiovascular risk factors at presentation. Some risk factors like diabetes and smoking are more potent contributors to AMI. And there's other non-traditional risk factors that we need to focus on. These include poverty status, stress, and depression, as well as people's lived experiences like bias and racism that contribute both to higher rates of AMI, higher morbidity, and worse recovery from AMI. In the Interheart study, this is a study of 52 countries. It was a case control study looking at potentially modifiable risk factors. There were 9 risk factors that explained 96% of the population attributable risk in women. The effects of these risk factors were observed similarly, across ages and across regions, but the most potent risk factors in women were smoking and lipoproteins. I highlighted in pink some of the other potent risk factors, and I wanted to draw your attention to abdominal obesity as well as psychosocial status. These are data looking at the pre-MI health status of young adults presenting with MI. These are data from the Virgo study led by Rachel Dreyer. And here you can see general health status as well as disease-specific health status, the SF-12 and the Seattle Angina Questionnaire and the EQ-5D. And here we're showing that when you look at men and women, higher scores are better. Women have consistently lower health status at the time of presentation for MI. And these factors also contribute to recovery. So these are things that we need to be paying a lot more attention to. In the HERS study, now this was a trial looking at healthy women who were randomized to hormone replacement therapy versus placebo, and they studied their cardiovascular outcomes in this trial. Here you can see that Black women had twice the mortality rate of white women. They had more hypertension, hyperlipidemia, diabetes at presentation, worse blood pressure and lipid control. They were less likely to be receiving statins and aspirin. And they speculated that there were other unexplained differences, including non-traditional risk factors like discrimination and racism at the point of care that were contributing to these differences. I'll say just a word about this because I know Dr. Barry Mertz is going to be speaking a lot more on this, but another reason when we look at this epidemiology that we can't ignore are the unique endotypes of MI in women. And younger women have much more prevalent rates of myocardial. When you look at data from the Virgo study, 1 in 8 women did not fit into the universal definition of MI. 1 in 5 women did not have a type 1 MI. And the mortality rate for these women is around 3.5%. I've listed some of the different endotypes, including some of the ones that Dr. Gibson was referring to, including coronary vasospasm, microvascular dysfunction, and missed MIs due to plaque erosion, which we don't see if we're just using angiography and don't do the additional analysis by OCT or IVUS. And these endotypes are virtually absent from the AMI guidelines. As Dr. Maida noted in a scientific statement of women with cardiovascular disease, if we look at the fuller group, despite being older, having greater risk factor burden and a greater symptom burden of angina, women paradoxically have less severe obstructive disease in their epicardial coronary arteries at elective angiography than men. I think this is a call for us to understand more about the sex-specific biology in women. I want to give a particular shout out to Dr. Gulati, who led our chest pain guidelines, and this is not for AMI, but this is for stable chest pain, looking at ischemia with no coronary artery disease. And as far as I could tell, it's the first US-based guidelines that actually have an algorithmic approach to INOCA, and I look forward to updated guidelines around acute myocardial infarction as well. So in conclusion, the incidence, morbidity, mortality of AMI in women remains high. There are worse health outcomes in young women compared with men, and among Black women compared with white women. There's an increasing prevalence of traditional cardiovascular risk factors, which may explain the increasing rates of AMI in young women, but there's also a lack of attention to social determinants of health and psychological well-being, which are consistently worse among women and contribute to health outcomes. We know that there's underuse of evidence-based medical therapies, and that there's sex-specific biology with persistent differences in the rigor of our diagnostic workups, and therefore contributing to a lack of evidence-based therapies for treatment and impacting prognostic outcomes. So thank you so much for allowing me to be here, and I look forward to the other talks today.